Marfan Hospital, she began to record the lecture for Renato Khalil. He's the head of congenital heart disease in Hospital Moinhos de Bento in Porto Alegre, no? He's okay. Is it okay?
Okay, let's start then. Thank you very much for the invitation. I will present now our experience with the Pears, personalized external aortic support for Marfan's ascending aortic aneurysms. I don't have conflicts of interest to disclose. Ascending aortic aneurysm may have the shape of the characteristic of the Marfan syndrome, where the sinus of Valsalva are involved, and there are other shapes as when the aortic valve is not involved or has no insufficiency. And the Pears is applied in both of these situations. Recently, the limits for indications for aortic root intervention in Marfan syndromes has been lowered to 4.5 centimeters for in cases where the operation is performed by experienced surgeons. So we should intervene with when the aneurysm is more than 4.5 centimeters. And the surgical thresholds might be adjusted based on patient genetics and the aortic growth rate. Our experience with Marfan syndrome with annular aortic ectasia comes from 1976, when we did our first 3 patients with a composite graft of the dura mater valve and the Dacron tube. This is this report we made in 78. And since then, as you know,
Dr. Khalil, sorry, you
yes.
show you are in the first slide. Can you show the different slide?
Yes, I'm changing here. It doesn't change there?
No.
Okay.
Now, yes.
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 It's changing now? Yes.
Yes.
Can I present like this? So are you seeing well the slides in this?
Very well.
Okay. So this is the surgical thresholds for aortic root ascending in ascending aorta aneurysm intervention. As I told you, this is Marfan's typical Marfan syndrome aneurysm and the non-Marfan syndromes, and this is our first report in 1978 of 3 patients with dura mater valves and a composite graft, the Dacron tube graft. And this is our first series of 27 patients. As you can see, the mortality was very low. It's 3.7%. And this has become a standard procedure with these good results presenting with all other centers around the world. So the conventional techniques for these situations are the Bental de Bono technique with the composite graft, and the David and the Jakub techniques where the aortic valve is preserved. In the objective to preserve the aortic valve, many other techniques are proposed, as the Hubschek wrap and the Florida sleeve, and more recently the Pears, the personalized external aortic root support. This aortic root support is a new approach to surgical management of the dilated aorta. It's effective to prevent and halt the aortic root expansion and maintain aortic valve function, especially in the situation of the Marfan syndrome. This support is made over 3D print of the aorta obtained in imaging technique as magnetic resonance or angiotomography. It's made a 3D print of the aorta, and over this, it's made an implant that covers the aorta of that patient. This is a video of the operation that will show as it comes downloading the video. I will show you right now. Takes some time. So this is the opening of the chest, conventional opening of the chest. The pericardium is partially opened, only in the superior part to expose the aorta. The aortic pressure is going down. It's a controlled hypotension is maintained during the operation in order to facilitate the management of the aorta, the traction of the aorta, and gentle dissection is made all around the aorta, freeing the aorta from the pulmonary artery and freeing also the coronary ostia and the initial coronary artery. This is the surgeon is separating the aorta from the pulmonary artery with electrocautery in very low power. Is gently dissected, preserving the adventitia of the aorta. The implant, personalized implant, is used as a guide to see the depth of the dissection. This dissection is going down to the aortic ventricular junction. As you can see, gentle dissection, freeing with this electrocautery and blunt dissection. Just down to the aortic ventricular junction. This is the right coronary sinus. The coronary arteries are also dissected. Now you can see the left coronary artery, trunk of the left coronary artery dissected. You can see here is the left coronary trunk. The orifices of the coronary arteries are made in the implant. This stitch that closes the implant is taken out. And the implant is opened in order to be cover the aorta. It will be gently passed behind the aorta and below the coronary ostia to cover all the sinuses of Valsalva. The implant is also moistened with liquid paraffin in order to to sleep. We have to sleep more gently over the aorta. Now it will be closed around it. Oh, now it's being passed behind the right coronary artery. And then it is closed with sutures with the lines that have been cut before. So this there is another video just showing the dissected coronary arteries to show more precisely this dissection that it is critical.
Okay, thanks. So this is.
Can you hear the sound?
The
video sound?
Yes, I can listen.
Less of the left coronary artery. Well, the line is right, over the max complex of the sinus of the then if I come up here anteriorly, I think this one you like. Up here.
So that was the left coronary artery, and now it will be shown the right one.
Left angle again, please. Really this side, quite clearly.
Fully dissected, and
For the max,
this coronary sinus dissected well below until the aortic and ventricular junction.
As I come around the corner.
And this is the non-coronary sinus dissected well below the until the, as I said, the ventricular aortic junction. And this is another video that one of the cases made here in Porto Alegre, where you can see the aorta.
Okay, right. So this is a 31-year-old lady, Marfan syndrome, and she's had a Pears applied off pump, a 95% Pears reduction, and this is her right coronary artery coming off here with a significant conal branch.
Sorry.
Video. Okay, right. So this
again.
is a 31-year-old lady, Marfan syndrome, and she's had a Pears applied off pump, a 95% Pears reduction, and this is her right coronary artery coming off here with a significant conal branch. And you can see if I lift up here that she's got the graft applied all the way down to the ventricular arterial junction. So what we'll do now is we'll just relax on that. Give me the yeah. Okay, and then we'll have the little measuring tape. Okay, so if we take the measuring tape and go under the right coronary artery, we can see that we have dissected under the right ventricular tract for a distance of 3 centimeters. So the whole of the non-coronary cusp, or sort of the right coronary cusp lines of Valsalva is covered. Give me the Dennis Bright, please. Okay, so down here, if you can see right in here, bring your camera over a little bit more vertical. This is the left main stem coronary artery. And this is underneath the left main, and you've got good coverage of the left coronary artery, sinus of Valsalva, with the Pears graft. And the left coronary artery comes off around here, very posteriorly. That's good. So we'll take this out from under the pulmonary artery. And now what I'm going to do is I'm going to lift up, and you'll get to see that the non-coronary cusp sinus of Valsalva is completely closed. The left coronary artery is coming out here between my forceps, and the whole of the non-coronary cusp sinus of Valsalva is secured to the ventricular arterial junction. The blood pressure at the moment is still 60, but it's coming up. Good.
So this is the preoperative angiogram, angiotomography of this patient's 30 years old female, and this is 1 month postoperative angiotomography, and this is the 20 months postoperative made in January last year of this same patient. We did a series of cases. I will present here some of them. This is the preoperative of this 39-year-old Marfan syndrome, preoperative and postoperative. And this is very interesting in this angiotomography. This is the preoperative, and in this postoperative angiogram, you can see the thickened aortic wall, with all the ascending aorta covered by the implant, as you can see here. So we did until November 23, 10 patients. In 24, we did another 3 patients that I will present following. And they were 8 Marfan syndromes and 2 with aortic, bicuspid aortic valve. And there was 2 with mild aortic regurgitation and 1 with mitral valve regurgitation that was also treated. Cardiopulmonary bypass was utilized in 4 of these patients because of the mitral valvuloplasty, the coronary anomalous aortic coronary origin, and another for reoperation, and another for the very fragile aorta. There were no deaths in this series. There was 1 case of postoperative pericarditis and 1 of atrial fibrillation. Times of length of hospitalization was 4 to 10 days, a median of 6.8 days. All patients made angiotomographies at 30 days and 1 year postoperative. It is interesting that the aortic insufficiency, aortic regurgitation, can be treated until, if it is mild or moderate, it can be reduced by this method. In our series, it was there were 2 patients with trace aortic regurgitation, 2 with mild. In these first 10 patients, they were reduced. And this is a case of a young doctor, 29 years old, with bicuspid aortic valve, dilated aorta, and anomalous origin of left coronary artery that had severe angina and sign of the low output syndrome on efforts. This operation was done as shown in this video. Part of it was without circulatory, without bypass, and part with bypass because it was necessary to treat the origin of the anomalous circumflex artery that arises from the right ventricular sinus.
Mainly about the
I'll
sinus.
show the video here.
But here we've got, just to hold that like that, we're just making a little, and so we've got a conal branch, a right coronary artery branch, and then we've got this abnormal circumflex, which is arising from the anterior sinus. and passing posterior. We've actually managed to dissect it out, and this is it passing under the maximal convexity of this posterior sinus of Valsalva, which is the node, probably is the node. But we've got round it here, and we can see also that the sinoatrial node branch is coming off this abnormal circumflex. That's it, thank you. And then all the way around here, we can see that it's below the level of the sinus of Valsalva. So we're hoping to put our Pears graft on between the aorta and the coronary artery and reduce it in size. But the last little bit of dissection, we're going to go on bypass, because we also want to just double check that the ostium of the right coronary artery is not stenotic. Just to show you, we've gone round over here as well. And oops, and over here we have the left coronary artery, which is fully dissected out and under the usual anatomy. It's coming out very laterally, but we've got right around it. Okay, there we go. There it is.
So this is the result of the aorta. This the control made in the immediate postoperative period, showing the mesh around the aorta, and the anomalous coronary artery with the osteoplasty well performed. And there are some examples of case. This is another patient, 32 years old, with Marfan syndrome. This is the preoperative angio, and this is the postoperative. This lady was 34 years old, similar to that, is the preoperative and postoperative angiogram. This patient was a reoperation of Marfan syndrome. He had a interposition graft a few years ago, and the sinus of Valsalva were dilating. She was treated with a Pears graft, and all the aorta sinus of Valsalva and the graft were covered with this implant. This was done with bypass. Was not done off pump as most of the other patients. And the final case I would like to show you is this patient with the previous. He was operated in the newborn period for a Jatini operation, was an arterial switch operation, and now he presented with dilated aorta and progressing aortic regurgitation. He had in 23 the aortic root with 52 millimeters of diameter and progressive aortic regurgitation. This is the magnetic resonance of this patient, showing the dilated aorta. Hopefully this video will run. This is the pulmonary artery riding the dilated aorta. And this video shows the dissection. The dissection of this case was done off pump.
All right, so we've got the main, this is the patient, he's a 26-year-old doctor. He's had an arterial switch operation. So he's got AP arrangement of the great vessels. And this is the pulmonary artery under the Comte maneuver. So this is the right pulmonary artery. And then this is the left pulmonary artery. He's got good mobility of the pulmonary arteries. And mixed stuff is. And so we're actually, we're right round underneath the main pulmonary artery. That over there, you can see that, which I'm hitting with a forceps. That is the left coronary artery. Coming off the left, facing sinus 1. And from sinus 2, we've got the right coronary artery. We've also got down there, that is the circumflex going retroaortic. and it's working its way down towards the ventricular myocardium. So we'll be able to work our way into this space here and get onto the coronary artery. But first of all, what we'll do is we'll transect the main pulmonary artery at this level, reflect this backwards, put our aortic cannula in up here, and then apply the graft. And have you got the graft? Yeah. Let's have a look at the graft. So this patient's aorta is 5 centimeters. And so this is where we have arranged for the longitudinal axial seam to be placed anteriorly. So between the left coronary artery and the right coronary artery, the circumflex is coming off like that and going around in this way, and the right coronary artery is coming off. So we're going to just mobilize all of this completely and apply the graft. And then this is an 80% graft, 80% it says on it. And that will be applied to the aorta. Hopefully that might recover the central bicuspid aortic valve disease. We'll let you know. Good.
Okay.
So the patient went to bypass. The pulmonary trunk was cut to expose the aorta, and this is the final result. Just after the bypass, with the aorta covered.
We've reconstructed the main pulmonary artery. We've transected the main pulmonary artery, and we've put on an 80% pairs. This is very interesting. This is the right coronary artery. And under here is the circumflex, with the graft lying now below the circumflex. The circumflex went backwards into the myocardium, so I was able to get the pairs graft right down underneath it. Looks great. And then the left is over here. A bit harder to see because the pulmonary artery is over the top of it. There's the left there, and you can see it goes all the way down to the, you've got the ruler. Regular. And pencil. There, so that's the ruler all the way down. 2.5 centimeters below the right coronary artery, almost 3 centimeters, right down in there. Oops, just made a bleed. That one. Okay, well, that looks really nice. Thank you.
Okay.
Yeah.
So, and this is the 3 months postoperative echocardiogram showing that the aorta has been reduced by a graph that was 80% of the size of the aorta. Now, the aorta that was 52 is now 37 millimeters in diameter, and the aortic regurgitation that was moderate now is mild, and we hope it will remain like that. Another technique that has been used with Pears is the so-called Ross-Pears operation that has been proposed by Dr. Conal Austin, that is mentoring us here in Porto Alegre to use Pears. He has a very good experience with this Ross-Pears. When you do the Ross operation, the complication that arises is the late dilation of the neo aorta, and if you cover it with Pears to prevent this later dilatation. The extent has an official registry of all operations made until the moment since more than 20 years ago. This is the clinical status of as of February 3 this year. There were 1,224 patients submitted to this operation. One of them is more than 20 years postoperative. 44 have more than 10 years, and almost 300 more than 5 years. The age of implantation goes from 3 to 80 years old. Most of them in the 20s, 30s, or 4th decades. The diseases treated with this operation are disease treated as operation, most of them of Marfan syndrome, but many others diseases of the aorta are also treated as a Loeys Dietz syndrome, the bicuspid aortic valve, idiopathic dilatation due to genetic syndromes, and some of later patients with tetralogy of the Fallot and transposition, and many patients with, as I told you, with the Ross procedure. This is the angiotomography of the first patients 15 years after the operation, showing the same preoperative and the 15 years post-operative, showing the same shape of the aorta. One characteristic in a patient that who died for another cause was that the aorta was examined, and it was demonstrated that there is a neovascularization in the outer layers of the adventitia, and the implant is fully incorporated in the aortic wall. And another characteristic was that seems to be a repair of the media, even if the aorta remains diseased. Because of the fibrin deficiency, the aorta, the histological examination showed that there is no that small dissections that appears late in the Marfan. So they support the aorta may recover with this technique. The success rate, the implant success rate is 97%. From 1,048 patients intended for aortic Pears, there were 28 conversions where the implant was not successful. The surgery was converted to another technique, and a total mortality of 0.3%. This surgery is being widely used in the UK. Most of centers are the United Kingdom, but there are many centers around the world, and the acceptance of this technique is being increased with many patients operating more recently. So, in conclusion, treatment of aortic root aneurysm with Pears is feasible, safe, and effective. The advantages in relation to the Bental de Bono, Yacoub, and Davis techniques are that implantation is feasible without cardiopulmonary bypass, avoiding direct intervention of the valve, and reducing valve insufficiency without touching the aortic valve. There are shorter surgery and hospitalization times. There is absence of anticoagulation, and the patients return to normal life without late aortic events in the long-term follow-up until the present. This is what I had to present to you, Dr. Ignacio, and thank you very much for the invitation.
Thank you a lot, Dr. Khalil. Your presentation was amazing and very, very nice data that you show and impressive surgeries that you perform. I think we have a lot of questions. I have a lot of questions for myself. I don't know if anyone have any question, or I have some questions. At the beginning, you show the surgery. If you can do it, you perform it without bypass in all the cases, or not?
Most of them are done without bypass. Most of them are off pump. We go on bypass when there are some complications. You need to treat an anomalous coronary ostium or a mitral valve, or there are many adhesions in a reoperation case. But if in a standard Marfan syndrome, it can be done without pump.
And when you, I am thinking about when you show the surgeries, I am thinking about you prefer the pressurized aorta because it is the normal size of the aorta and the physiological situation. I think this is better for your prosthesis. No, it is right at that point. This is the
Yes,
reason use that you don't use bypass. I think obviously if you avoid the bypass, it's better because you avoid a lot of problems. But I think in the geometry, you have a better geometry if the pump is beating than if the pump is not beating. I think I don't know if it is true. This
it might be true. Yes, it might be true. We keep the blood pressure very low. Yeah, with a medium of 50 and 60, maximum systolic blood pressure in the 70 or 80. And with this low blood pressure, we can manage the aorta with low risk of tearing it down. And I think it preserves the shape in order to orientate better the implant.
and the other question is when you pass through the coronaries. This is the critical point. I think in more and most important when you have a redo. But the question is, you fix the prosthesis from outside to the annulus or not? This is one of the questions that I have. And the other is when you fix the prosthesis, you looking the transesophageal echo to understand how is the valve? Because I did some experiments about some elastic rings because the concept that you show, it is very physiological concept to reduce the aortic valve regurgitation. And this is very nice concept because you treat from outside and you never touch the leaflet. And I suppose, I don't know, and this is the other question. I have a lot of questions in this, but answer this and then I ask more questions.
No, the dissection goes until the origin of the aorta in the aortic ventricular junction, the nadir of the aorta. In the Marfan's patients, this is 2 or 3 centimeters below the coronary ostium, you know? And it has to go there to better cover the aorta and to reduce the aortic insufficiency. In this last patient, as the Jatini operation, we programmed an implant that was 80% of the aortic size. So it was reduced by 20% of this original size. And this reduced the aortic regurgitation very nicely.
And this reduction, this 20% reduction, you measure before, you calculate before how you want to reduce?
Yes. The implant is produced with the size we order to be produced. Usually 95%, and in some cases 80% or 90%, decided by individual cases.
Okay, and this has a better follow-up, probably, or a better behavior of his native aortic tissue because you never touch the coronaries or you never touch the valve, and the aortic disease is a big problem, and a lot of patients will die for this problem. And I think if you do something that you change the geometry and that's all, and you improve the aortic regurgitation, it is a lot. And the other question is, do you show a little number of patients with coronary problems? and this is a very important thing because. But and the other question is, what is the limit, the low weight that you use this technique? What is the lowest weight of the patient that
of
you can?
patients.
Yes,
It
that
depends on the size of the aorta. It depends on the size of the aorta and not in the patient size. If the aorta has more than 2.5 centimeters, 3 centimeters, you can use operation, and the aorta already has an adult size. So the youngest patient was 3 years old. And he had a huge aorta. In our series, the youngest patient was 10 years old with Marfan syndrome, and he had a very large aorta that was reduced also. But so it depends on the aorta, the size of the aorta.
okay. And what is the material of these prostheses, and where do you buy these prostheses?
It's a polyester, similar to DACO, and it is produced by Extent in London, near London, and it has no registry yet in Brazil or in South America or in North America. So we are using this under a research project in Brazil that we were liberated to do this as a pilot research project.
And do you know, perhaps not, but do you know if this technique change the mortality when you compare with Tyron David technique? Do you know if how is the morbidity and the mortality between both techniques? Do you know something about that?
There is no comparison, but in this registry of the existent industry, they had more than 1,000 patients with no late the complications of the aorta. There is one late death that was not the cardiac causes, and there are some operations to replace the aortic valve in patients with bicuspid aortic valve, but there is no late complications of the aorta itself. It's very impressive, the results.
Yes, probably. Yes, yes. I like a lot. Sincerely, I like a lot because when I work in the lab, I prepare a pulsatile setup with a big heart, and I put from outside an elastic ring, and but this is much better because when you put something this polyester, I think how to see in English, but the pulsatility of the wall of the aorta, this material go with the same motion. I don't know how
Yeah.
is acompañar, but both tissue, the prosthesis and the aortic wall go outside and inside. The pulsatility, it is a good point. And the last question that I have, sorry, is do you know when happen the histological changes that you show? How much time need the patient to produce this kind of histological change?
Yeah, I don't know. We don't know. We just have one case of recovered aorta to do a histologic study. This we will know in the future, but we don't have this answer now.
Okay. Okay, Dr. Khalil, thank you a lot. Thank you, and perhaps I will visit you. I like this technique. I want to learn more, and it is important. I like a lot this. Thank you a lot.
Thank you very much for the invitation. It was a pleasure to present you. We will be at Gramado. There is a Brazilian Congress of pediatric cardiology in Gramado next week on 19 to 22. If you come to visit us, it will be a pleasure.
This is the Snow Center, no, in Gramado.
Yes,
The artificial. Yes.
Yeah.
Okay. I don't
Okay,
know
thank
if
you very much.
someone has any question. ¿Los chicos tienen alguna pregunta? No. No. Thank you very much. Bye bye.
Thank you. Bye-bye. Have a nice week.
Bye bye.